Our presentation today is about the study we did about the occult hepatitis C infection in patients with on hemodialysis. I would like to thank Professor Dr. Noha Naqib, Professor Dr. Mu'taz Said, and Dr. Amira Al-Araishi for their effort to complete this work. We declare no conflict of interest in the study and the approval of Ain Shams University Ethical Committee for the study. The contents of our talk today are going to be the introduction and aim of our study, the methodology, the results of our study, and the conclusion. So, occult hepatitis C is the presence of hepatitis C virus RNA in the liver tissue and/or peripheral blood mononuclear cells with undetectable hepatitis C RNA in the antibody or antibodies in the serum. This was described by Castillo et al. In 2005, where he found hepatitis C virus replicating in peripheral blood mononuclear cells. In the liver biopsies, patients with chronic hepatitis C had frequently more necroinflammation, more fibrosis than occult hepatitis C patients, but liver cirrhosis was diagnosed in a similar frequency in both groups. This was a study done by Pardo et al. In 2007. It is well known that hemodialysis patients have an increased risk of infection for chronic hepatitis C due to nosocomial infection, vascular access, and to the recurrent blood transfusion. So in our study, we aim to evaluate the prevalence of occult hepatitis C among patients on maintenance hemodialysis. Our secondary aim was to study the predictors of occult C in hemodialysis patients, where clinical laboratory parameters were studied in occult hepatitis C patients and other patients with end-stage renal disease. The patients and methods of our study: 60 end-stage renal disease patients on hemodialysis were studied with negative hepatitis C virus RNA and negative hepatitis C antibody by ELISA. Patients with confirmed hepatitis B and C or C were excluded from the study. And we did a study for the PCR of the hepatitis C RNA in the peripheral blood mononuclear cells of those patients. And then the patients subsequently were divided into two groups, occult C positive and negative groups, where clinical imaging and laboratory parameters were studied in both groups. The results of our study was that patients with average age of 48 and male to female ratio of 11:9 were the population of our study. 6.7% of them had history of blood transfusion. The main cause of end-stage renal disease was mainly hypertension in 50% of the patients, diabetes in 20% of the patients, and less common causes like polycystic kidney disease, recurrent urinary tract infections were also present. The prevalence of occult hepatitis C was 11.7%, which is 7 patients of the 60 patients studied. In comparing the clinical and ultrasound findings in both occult C positive and negative cases, we found that ascites, lower limb edema, and jaundice were both clinically prevalent, more common, and significantly in patients with occult hepatitis C than patients with occult C negative patients. So on applying the logistic regression analysis, we found that bilirubin, total and direct bilirubin, were predictors for the presence of occult C in hemodialysis patients. And by putting that on our curve, we found that a cutoff value of 1.7 for total bilirubin and 0.4 for direct bilirubin were the cutoff values to predict the occult C in hemodialysis patients. So in our conclusion, we believe that hemodialysis patients are liable for occult hepatitis C infection with a considerable impact on their health. Total and direct bilirubin are predictors of the presence of occult C with cutoff values of 1.7 and 0.4 milligram per deciliter respectively. So thank you. That's the end of my discussion.